Oh, okay. So welcome back, the audience. Maybe you take your seats. Hyo-Soo, we're back. Thank you very much. Now seeing you live in action with your team.
Okay. Yeah, welcome to SNU Hospital. I'm HS Kim. My helper is Dr. Jeehoon Kang and Ki-Wan Lee. My first case is TAVR with accurate nail 2. The second case is a complex PCI with heavy calcification. I just treated the RCA lesion just before, and the tema of the second case is LAD. Let me introduce the first case of TAVR. Can you see the slide?
Not yet.
Okay. Slide, please.
Now we can.
68 years old female patient is receiving regular follow-up care for diffuse systemic sclerosis and interstitial lung disease. Severe AS was diagnosed on workup for progressive dyspnea. SAVR was initially considered, but TAVR was recommended due to extremely high surgical risk associated with poor lung condition. Plus, a target is AS on the background of diffuse systemic sclerosis associated with interstitial lung disease. Plus, echo showed normal ejection fraction with severe AS. CT angio showed tricuspid aortic valve with calcification and thickening. No evidence of atherosclerosis in coronary artery. PFT, FEV1 and FEV-C ratio is about 80% compared to peer group. DLCO, diffusion capacity, is very poor, 26%. Plus, current medications from rheumatology and pulmonology, in addition to cardiology. Plus, ST score is just 4.9%, which reflects the not seriously considering DILD condition. Plus, as you can see on the left, bilateral reticular opacity is well observed. ECG was normal. Plus, echo showed a normal ejection fraction with concentric hypertrophy, severe AS. Plus, Max is over 4.1 meter per sec, and valve area is 0.9 square centimeters. Mean gradient is about 38. Plus, annulus on the left side and alveolus on the right side. The size is about 23 and 22. In center, you can see the very few balanced calcification along the three cusps. Plus, coronary height is about 11 or 10 or 14%. ST junction height is more than 15. ST junction size is 29, big enough, without calcification. Left and right coronary sinus is more than 30 millimeters. No chance of coronary obstruction. Plus, best angle for implantation is LAO caudal. Plus, I prepared two issues. The first one is valve type selection among 3 available valves in Korea: Sapien, Evolut, Accurate. The second issue is cerebral protection. Plus, I'd like to introduce Accurate nail for this case. This case also treated with other valve, but I focus on the introduction of new Accurate nail 2 valve in Korea. We can see the upper crown and stabilization arch and lower crown. There are 3 components. That is related with 3 steps of release. First, upper crown is released with very cautious mode, followed by stabilization arch deployment. Then the valve is fixed at the distal part, upper part. Then final release is a lower crown release with very rapid deployment to avoid the movement. The landing zone is shown in 7 millimeters. That is the center of the lower part of the valve. that is about 15 millimeters. Landing zone diameter is shown in lower crown diameter. That is 3 millimeter bigger than waist diameter. Waist diameter is a nominal diameter. In other words, when we see the accurate nail to 25 millimeter valve, actual lower crown diameter is 28 millimeter. Please remember, because it is very important to decide ideal oversizing index. Plus, it has several good things. First, it is an open frame, providing easy accessibility to coronary ostium. It's very similar to sapien. It is supraannular structure, providing wide orifice area and low remaining gradient. It's very similar to alveolate. Plus, accurate nail has most clinical conditions favoring itself. I described 9 clinical conditions determining choice of valve among sapien, accurate, alveolate. The first 4 clinical conditions favor sapien: risk of leakage, horizontal heart, risk of AV block, future coronary accessibility. Remaining 5 clinical conditions favor alveolate: risk of coronary obstruction, risk of tear due to alveolar calcification, valve thrombosis, orifice area, pressure gradient, the risk of dissection due to small tortuous aorta. As you can see, accurate center has most widest clinical conditions favoring itself because it has some kind of feature of sapien as well as it is similar features with alveolate. It is self-expandable, thus similar to alveolate. But it has a little bit softer expansile force, leading to less chance of AV block, and it has a wide frame, thus it provides coronary accessibility. Wonderful. Plus, for this case, annulus perimeter is about 73 millimeters. That corresponds to nail to 25 millimeter valve. Actual diameter of lower crown is 28 millimeter. Thus, oversizing index is about 20%. That is my favorite ideal digit to reduce the leakage possibility, not increase the AV block. Plus, one important thing of accurate nail is we can manipulate commissural alignment. It is a little bit difficult, impossible in case of sapien. Sapien is not necessary in case of alveolate. On the right side, we can see the post, and on the fluoroscope, we can see the open cell that corresponds to post. That is noted by the red bar. Thus, in the LAO view, we can see the open cell both sides symmetrically, while on the RA view, the other open cell is anterior. Then we can expect such kind of arrangement of post that is far from ostium of left and right coronary artery. Plus, on the actual fluoroscopy, here, step 2 is tricuspid view. Always it is LAO view. On the right side, we can see the symmetric protrusion of open cell, free cell. Then we have to turn the fluoro on the RAO view. Then the third open cell should be anterior. Then plus, we can expect such a kind of orientation. Thus, with this maneuver, we can make the ideal commissural alignment using accurate nail. Plus, the second issue is cerebral protection device. Who should be protected from stroke? I consider 2 factors may determine the necessity of protection. First is the impact of stroke. Young age with long life expectancy should be protected. Feature procedures, VIP TAVI and bicuspid TAVI is always associated large amount of tissue embolization. Plus, this patient is only 68 years old. Thus, I decided to use Sentinel to protect brain. It is composed of proximal filter that is 15 by 40 millimeters, and distal filter 10 by 45 millimeters. On the right side, you can see the anatomy of brachiocephalic trunk and left common carotid artery for these patients. The ostium of brachiocephalic trunk has some plaque, but it is not a big deal. Plus, the PROTECT TAVR trial showed no significant primary endpoint between Sentinel versus placebo, but Sentinel reduced the incidence of disabling stroke. Thus, I believe some kind of efficacy of Sentinel to protect brain. Okay, this is the presentation, and then we can show the fluoroscopic image that was taken until now. Fluoro, please. Fluoro. Okay, plus. Then we introduce Sentinel, plus. Confirm the location we deployed proximal filter, plus. We put the pigtail around to expect the level of bifurcation, plus. Proximal filter is deployed at the midpoint of brachiocephalic trunk, plus. With manipulation of articulation part, plus. We introduced the wire into the left common carotid artery and then retrieved the whole system to make the contact of articulation part and bifurcation between brachiocephalic trunk and left common carotid artery, plus. We deployed the distal filter. Then we show the double tracing pressure profile. As you can see, pressure profile. Pressure 너무 높다. technician이 그건가? Okay, there is a not so remarkable pressure gradient between two chambers. Okay, that is the progress that we have taken today. Is there any comment? Question?
Okay, so and Professor Kim, thank you for your very nice presentation for briefing for patient. And any question or any comment from the panel and audience?
No, I think it's as usual from him. It's extremely didactic. He's always reasoning what he's doing, why he's doing it, and how he's doing it. So it's very educational. Arguably, his judgment between the three valves, you could argue, but that's his opinion, and he made his choice to do the actuate. Personally, I believe you can do any of those valves, the one that you are most familiar with. But I really enjoyed the presentations with him, I have to say. Sentinel here is a good choice. The only thing that I disagree with is this young age stroke is more value than in older.
Yeah.
But
yes, Alan, how about yes, accurate nail?
So now I know if I have to do a TAVR, you won't be Sentinel doing Sentinel on me.
Okay, you're young, so you have it forever young. Yeah.
I will put it in.
We know in US obviously finishing study of the Neo Accurate 2, Accurate Neo 2. So I think it's a good valve. It's easy to deploy. The only question is that 20% oversize in the underskirt and how much it presses on the LVOT and whether pacer rate is it high or low. I think that's still kind of a bit of a debate. What do you think? Is it pacemaker rate low?
Yeah. Oversize index 20%, and the actual diameter base is about 10% oversizing nominal diameter. That's usually you use a nominal diameter-based oversize index. That would be about 10% for this case.
Okay, Michael, do you have comment?
No, I'm just saying that if Eberhard is going to do TAVR, I'm going to put in a
Accurate
sentiment.
nail is also available in Hong Kong?
Yes, we have it. We don't have much experience. We're just starting the Accurate Nail 2 program. But my question is it mandatory to do a pre-dilatation for Accurate Nail 2?
Yes.
Yes.
Okay.
Plus, test it. Because the frame is very soft, thus they always recommend pre-dilation.
See,
So,
left.
pacing,
You know, the question really is when you have
Deflation.
two self-expanding valves, do you need 2 valves, 3 valves, 4 valves?
Right.
You know, so,
I think, each valve, the procedure is pretty standard in terms of steps, but each valve has its own nuance.
yeah.
And if you're not have done enough of it and you forget, and then you get in trouble. So I don't know, for me, I only can deal with 2 valves.
Right.
3 is getting a little hard for me. 4, forget it, so.
How about James and the Northwestern experience and another valve like Accurate Nail 2 or?
You know, it's been in the trial, and we weren't in the trial, but also the Navitar is being introduced in the United States. So now we have 3 self-expanding platforms, and it's good to have choices, but the space is getting a little crowded in terms of having expertise in every valve.
Yeah, I think it is, but it's an important point. You can try every valve, but
twice the
what,
You got to be comfortable.
best angle.
so, because he said it already, and as usual, he's very educational, but it's a top-down deployment. It's not the deployment that we are used to, so.
So advance. Twice the.
But you recall, he was also a big fan of Lotus.
Okay. Just from now on, we pay attention to the location of free cell.
Yeah,
As you can see, the free cell appears in both sides simultaneously. Can you recognize it?
Yeah.
yes.
Yes.
Okay, I can take it as there's a minor protrusion of wire on both sides. Then I maintain such kind of orientation until the advance to the annulus.
Oh, I'm sure it's Safari. Professor Kim, the Safari wire, what wire do you use?
Is it
Yeah,
Safari
Safari
wire?
wire.
Okay.
Yeah. Then I check the third free cell on the RA view. 좀 더. As you can see, the third free cell is anterior side. Then we can expect the free cell location is well aligned, avoid from the coronary ostium. Then I advance the whole system to the anterior annulus test. Okay.
Yeah.
Just test it.
So you see the marker.
Okay. Center marker should be at the annulus level, not above annulus, just coincide with annulus level.
Like now.
Looks good.
Test. The initial position is very important. Test. Okay, I think the position is good. 120 pacing,
120회
120 pacing. Okay.
So the first part is, as you all know, very controlled and very slow for the upper
Test it.
crown.
테스트?
가이
그게 잘 안 맞네, 우리게. 자, 테스트? Okay, it's good. 자, we can start slow release for the first upper crown. Slow,
start deploying slowly
slow. slow, slow. Work test. The location is good.
Yeah, very good.
Here we see the expansion of upper crown. Then we are going to slowly release the stabilization arch at the second step. Deploy, deploy, slow, slow, test it. Okay, a little bit deep. Deploy. Okay. 저장하고요. You can see the stabilization arch is deployed. Thus, theoretically, the device should be fixed. But in my experience, the third deployment process, the device will move upside or downside. We cannot expect, but the movement is very little.
Yeah, and this part now is fairly quickly.
Yeah. Test. A little bit there. But I can start the deployment. 자, 뽑았어.
Yeah.
I can do a rapid deployment. Deploy, rapid.
Bingo.
오케이. 저장하고요. 자, 테스트 해볼게요. 테스트. Depth is good. 저장하고요.
Do you usually keep the pigtail behind or pull the pigtail before you fully deploy?
Facing up. I usually put the pigtail there because I don't have any trouble while I introduce wire and retrieve the pigtail.
But Michael, that's an important question because you have the arches and the picture can.
Okay.
Eberhard, so we have discussed early on in the lunch symposium about, LVOT calcium, valve calcium, and also STJ calcium. So
Sure.
for this type of valve on the stabilization arch, they're relatively soft. So even with LVOT calcification, STJ calcification is seems to be okay because
Yeah.
you're basically just holding it, but not exerting a lot
No,
of force.
no.
Is that fair?
Yeah, that's fair to, yeah.
테르모.
I mean, you can see it has this large open cell design for coronary access. Let's see how he rated the actuate with 2 on PVL.
Okay, they use the thermal wire and pull back the pigtail.
Yeah.
See this?
There was at least mild PVL.
I removed pigtail. At this time, I would like to check once more the level of valve. 맞췄나? parallax. Okay, snap. Yeah, depth is good, but there is subtle regurgitation, probably due to the wire. Okay, we can see the T, please.
It looks, at least in part, paravalvular on the left.
Okay.
픽들 준비하고요.
It seems like its ascending order is bigger than those stabilization arch. It's just kind of floating in there right now.
So, Dr. Kim, do you usually do TE for TAVR or is it only specific for arcuate neo?
Yeah, for live demonstration, we do T because T provides a very good image. In the ordinary practice, we don't use T.
There's paravalvular leakage on the superior, I think, between mitral valve and aortic valve. it is more than mild degree. I'll show you another short axis view.
내가 말할 테니까 이미지만 잘 보여주면 돼.
Yes. Could you show us the how amount of the PVR in the by the aortogram there would be some at least mild?
As you can see, the T image, most of the leakage is within the valve. Too much intravalvular regurgitation. You can see minor leakage on the 12 o'clock. I just manipulate the ventricular pictal catheter to make some change of intravalvular regurgitation.
Yeah, there's two jets. One is from the wire and one is paravalvular.
Yeah. So it would be helpful to change the pigtail in LV.
Yeah, I already switched from a wire to a pigtail plus here. And then I move the position pigtail by rotating. It's a short axis view. Cross-section image. Cross-section. Most of regurgitation is intravalvular.
Yeah.
Although you could be fooled in this view because you have to be at the precise level.
Okay. longitudinal 한번 볼까요?
Yeah, but I
Longitudinal.
think there's also some degree of outside.
Yeah, on the left, yeah, sure.
이렇게 제 이유가 뭐지? 희한하네. Mainly intravalvular.
둘이 양은 비슷한 것 같습니다.
Okay, just 한번 rotation 해볼까? Let us check the full expansion of valve frame by rotating fluoroscopy. 자, start areocaudal, areocranial. As you can see, the smallest diameter in areocaudal view and a little bit expanded on the other projection angle. This is valve 20% oversizing and the actual diameter base and 10% oversizing in nominal diameter base. Okay, I'd like to check once again the, okay, 저 T 좀 빼주지. 자기 끝났으면 빼야지.
You can check the AR index right here. Before.
Okay, once again. 다 없나? Okay. Okay, we can show the AR index.
다 됐어.
다 됐어? Okay, pressure.
Okay.
다시 한 번. Flushing again. Flushing 할까?
It's
Flush again.
about I don't have experience accurate neo 2 in Asa Medical Center, and is it possible to further dilation after implantation of accurate neo 2? Is it,
Yeah.
Of course, of course. Expansile force of accurate nail, scaffolding force of accurate nail is a little bit weaker than avalate. That is associated with less chance of AV block compared with avalate. Pressure 108, 65, 42, 22. Pressure 보여줘야지.
is a simultaneous press monitoring
106.
looks okay, and
64, 41, 21. 그다음
the AR index
그것
seems to
보여주고,
be
AR index
30
보여주고.
and
But really, the goal is trace AI. It's not an index
그냥
measured AI
보여주면 되지.
anymore. Yeah, we're looking for trace. We'll accept mild if there's a lot of calcium or other treachery, but we really want trace.
Okay, we devised new AR index compared with AR index. And AR index, about 20, new AR index about 30.7. New AR index is more accurate than traditional AR index because we adopt the pressure difference between dicarot notch and end diastolic pressure. That is actual diastolic phase and the decline of pressure profile during diastolic phase. There's always new AR index is better than traditional AR index. What was cutoff value?
25 and 3.
25 and 3.3. Thus, in new AR index, it is acceptable, but traditional AR index, it is a little bit leakage. Okay, that is kind of reference. We can show you the angiograph once again. 자, 쓰네.
I think you're going to need to balloon that.
What to do? We have to do balloon inflation or just removal of pigtail?
I mean, there's not a lot of LVOT. I think you could safely balloon that. But that's a mild to moderate leak.
Yeah. We can leave it like
Which
that.
balloon?
It's probably
Balloon
moderate.
size?
Balloon size
Huh?
What size balloon do you use for this
Okay.
type of post-dilatation?
23?
23.
Okay. We are going to do additional ballooning using 23 millimeter balloon.
How do you size that, Professor Kim? How do you decide 23 for 25? This is 25 accurate, right?
To manipulate, to adjust the inflation volume. And usually we adopt the size based on the annulus median diameter, average diameter.
So now the crown seems touching the STJ. Is there any concern for post-dilatation?
Minus.
So in the the panelist question about during the post dilation, is there any SJ the junction concern about the damage or something like
Just
that?
above the left corner.
Yeah,
You
yeah.
see it there, right? So, but it's a 23. The bottom, it's supposed to be a 25, but it's hard to know. But just be gentle, I guess.
Yeah, I wouldn't expect the top of the frame to grow any with the 23.
Why
Yes,
so?
go ahead.
Julio?
Yeah, hold
Go
it.
ahead.
Julio.
Okay, Mike?
So we cannot exclude that the pigtail is not interfering with aortic insufficiency. It would be more appropriate to repeat an angiography without nothing in the ventricle.
The problem with that is, if you pull back, then you have to make sure that,
Full inflation.
you don't cross the wire.
The company always recommend the balloon position of post tail just below the post because they try to avoid the balloon damage to leaflet. Because this position is what they recommend. So pacing, inflation, deflation.
Yeah, the frame expanded on the left. You can see that.
조정하고.
And I wouldn't pull the wire because it could get caught behind that upper cell, and that could be a problem.
Those things are kind of floating there.
And they're not very strong,
Touching.
so you could damage it
Okay, pigtail,
trying to cross it with a balloon.
Well, we'll see.
pigtail.
It definitely expanded a little
Did.
bit.
We should
Can you
take
show this again?
Can you show that ballooning again? Do you have it saved?
Ballooning again, please.
Other caudal? Yeah, definitely. The frame is expanded at the area caudal. Show the narrowest diameter of valve frame. 오케이, 다시 AP 안전이. 다시 flushing again. T2하고. 아, 자기가 왔다 갔다 하는구나.
In T, we could also see the commissural alignment. That was well positioned.
밑에는 프레셔 프로파일 보여주고, T 보여주고,
네.
거기서 빨리빨리 움직여야지, 바깥에서.
Give us the color, please.
Still a small leak there. But
Yeah.
I think we need an aortogram to see how much improved it is.
자, 프레셔 밑에 내리고. 잠깐 프레셔 놔둬볼까? T 좀 제대로 보게. 오케이. 111, 70, 44, 22.
See.
오케이. T 좀 보여주시고.
Okay.
Commissural alignment. First 같다.
아까 커미션 보여줘볼까?
여기
We can see the three posts. Cross section.
should access post. 아까 짠짠짠. should access.
Cross section. Okay. NGO. 크로스 섹션 보여달라니까.
라이브로 보여주세요.
You can see the position of post. That is far from the ostium of left main and RC. Okay, T 빼고. I removed out the ventricular pigtail catheter. Then I will show you the final arterography. 스내 준비. Because mainly it was induced by catheter. Okay, 다른 비율 없고 LAO.
No, I think it was real paravalvular, and I think it's better with the dilation.
The contrast looks like it's coming from outside.
Yeah, certainly on the left,
Doesn't
it
look
was
like
outside
it's
the frame.
inside, yeah. The pigtail doesn't generate that much.
Audio coder. Audio coder.
There's still a small leak, but it's better.
Yes, it would be better to delineate the amount of the AR and to put the multi-pigtail.
I was curious about the reason of paravalvular leakage because oversize index is full and the valvular calcification is really little, no commissural heavy calcification. But what's the reason of such kind of trivial paravalvular leakage? Wrong calculation of annular size? This is a contrast to my expectation. I expect perfect, no leakage, based on my previous experience with Accurate. But there is a trivial regurgitation leakage here. I don't know the reason. Okay, minus. First, let me conclude the Accurate Neo TAVI live demo. I think, as I shown before, there are most common clinical conditions to favor the Accurate Neo. Thus, I think Accurate Neo has good things from both Sapien and Eberhard. Thus, I expect Accurate Neo may be workhorse for TAVI procedure. In specific indications, they choose Sapien or Eberhard, but now the Yeung doctors who are not well trained with sapien and pre-existing evolute, they may learn to deploy accurate nail first, then learn to do sapien and evolute.
Okay. So, and Eberhard, you are expert in
Nope.
evolute. And
yeah.
Alan, you are expert in the sapien. And any comment for?
No, I think it's as I said, I think it was a wonderful deployment. That's what we see with Actuate, and I think you can see its positives, but you can see maybe the features that you might not like so much. But basically, as usual, he did a very, very good job deploying it. I don't think it's trivial, by the way, but it's arguably with AR, it looks a little bit different from each. But you can see here now, if you try to re-enter the ventricle now, with these large arches, it's very difficult to, or it's tricky to get really into the right track, not to go behind them. And I don't think that you can do more with this valve now. And the question is whether you need it or not. I think you can leave it. I think it's fine.
I mean, the trade-off between the strength of self-expansion versus how much you can push a calcified valve apart and keep them there. I think you try to sort of say, well, you don't need as much so that you have less pacemaker complication. But what you do is that the valve, this whole thing is a little softer, a little bit sort of, you can see it twisted a little bit. So I think the compromise and how much do you want to, again, which way, and is
what you could also see, the inflow was a little bit bent in. We saw this in the early days when the cover was too high. We had this little bend inside,
Great.
Okay, so, and thank you, and very nice result, and this is very helpful to demonstrate how can you implant accurate nail, and Professor H.S. Kim is moved to another complex PCI room. This is a different story, and the first story is about complex TAVR. This is a complex PCI. Okay, and Professor Kim, can you start your complex PCI?
Yes, welcome again to the live demo in SNU Hospital. I introduce the second case, complex PCI of calcified lesion. Slide, please. Plus. This patient is 8 years old male who was diagnosed as ischemic cardiomyopathy last year. At that time, he was admitted to our hospital due to aggravating dyspnea with severely decreased LV function, ejection fraction just 22%. Angiogram identified severe three-vessel disease with heavy calcification. At that time, only RCA was revascularized. Plus. At that time, ejection fraction was very poor. Thus, we just treat most critical lesion on RCA. Plus. Last year's angiography, RCA was stenosed at proximal and mid portion. There is really a tortuous at mid part of RCA. Additionally, LAD, there are tandem lesions along the left main to mid to distal LAD with calcification. Big diagonal has also disease. Circumflex is very small and nearly totally occluded. Plus. Last year, we treat, Dr. Hwang treat this patient mid-RCA with just balloon because it was impossible to advance stent. Balloon is well expanded, as shown here, plus. Then proximal RCA was treated with stent. DS 2.5 by 15 plus. Before and after RCA PCI last year. Proximal RCA treated with DS, mid RCA just ballooning plus. And 1 year later, last week, the patients experienced recurrence of angina. Thus, we took chest X-ray, normal. ECG is normal, no OMI. All myocardium will be viable and hibernating. Plus, echo last week improved up to 40%. Plus, still, SPECT suggests partially reversible ischemic territory in RCA and LAD. Plus, just last week, Dr. Hwang treated RCA again. Plus, angiogram shows restenosis of mid-RCA treated with balloon. Patent stent at proximal RCA. Left coronary artery is no change. Plus, the last week, Dr. Hwang treated the mid-RCA recurrent lesions. It is very difficult to advance. Thus, he first fully inflated proximal stent, then he was able to reach balloon to mid-RCA after tortuous calcified RCA. Plus, many repeated inflation by 2.5 millimeter balloon. Plus, before, after, a little bit improved, but still there is a recoil of mid-RCA lesion. Plus, thus, let me show the image that I took before TAVR procedure. Floor, please. Minus. Okay, plus. Under the backup support of IABP, I introduced catheter on RCA. It was very difficult because of tortuous calcified aorta. So as you can see, I use long sheaths. We can see the recoil of mid-RCA lesion plus. So I really struggle to reach balloon to the mid-RCA lesion and fully dilated using 2.0 to 0 balloon. To 5 balloon was not advanced until the tortuous calcified mid-RCA lesion. Plus. It looks better. Thus, finally. Thus, I try to treat LAD. That is another important branch, heavily calcified, leading to reversible ischemia and LAD territory. Plus. Here is the LAD angiography. We can see the proximal LAD tight lesion, short left main, tight lesion, and mid-RCA, there are several tandem calcified lesions. Thus, it is a very tough case. That's the reason why I use IABP. Final? Plus. So Dr. Wang advanced wire while I do TAVI. Plus. Here we can see the proximal LAD showed a very tight lesion. Plus. Okay. Then we are going to do rotor ablation and balloon angioplasty and DS implantation.
Okay, at this moment, we're going to have some discussion time. I think this patient is typical, one of the most the typical case shown in the TCTAP live case. 88-year-old female and the very severe calcified region, ejection fraction initially is 22, is much improved, 40. This is absolutely candidate of revive the trial is presented the last ESC meeting. And any comment or any question?
Although he presented with angina, that was less of an angina trial, so I think in the treatment of angina, Revasc is okay here. The question is, was it the right coronary or the LAD? The LAD looks a little worse to me than it did on the older film, so maybe both arteries.
So any comment about the age concern? It's 88-year-old female for.
We have shockwave, right? We have shockwave.
Yes, so we do now is the proper scheme is try to do rotablation.
Yeah, I think a shockwave would be hard to deliver here.
That's right.
So
I think the
diffuse.
mid-right is a pain.
Yeah.
Because of that tortuosity and then with calcification. The question is, would you try rotablator of the right? Small burr and trying to maybe have to use a guideliner and going through
Very
a 1
acute
to
angle,
5.
so you worry about
I know.
perforation with the
Yeah,
acute angle.
and also a couple of screws.
그래,
screw
줘야지.
turns.
And this case in US usually do shockwave, right? Oh.
No.
Well, I think shockwave would be very difficult to deliver in this anatomy without atherectomy first.
The mid-right is a.
Sometimes
is
you
a-
combine shockwave after.
Also, how about the MC? This patient, the ejection fraction is 22, and this is supported. The IBP is the reason why impeller is not available in Korea is how about US? Usually do use the impeller.
Well, I think it depends on, we haven't seen the peripheral anatomy, and the ejection fraction, it did go up to 40%. I'd be interested in the LVEDP or some hemodynamic data before saying,
So I
Impella.
really do agree with you. This is a very challenging case.
Absolutely.
And, very difficult to
Yeah,
do.
very difficult case.
I don't think that shockwave would reach the right,
no,
No chance.
not without modification.
because, it's still a balloon, but it's,
Okay, balloon.
DW, do you have drug-coated balloon in Korea? Drug-coated balloon for
Shockwave is not yet available in the. I heard in Japan is available shockwave.
no the drug-coated balloon for the
D-
right.
Yeah,
DCB for the
yeah,
right.
DCB
is
for the right.
available. Yeah.
Okay,
They
that might
also-
be a choice if the stents won't go.
May also be tough to deliver.
This case, in my opinion, is a very high risk for the no reflow or slow flow after
Yeah,
rotational ablation. Old age person and also low LVEF. So, putting the IABP is one of the good option. So, in this case, in Europe or other countries, how did you
그러니까 본론을 해야
prepare to prevent the slow flow, no reflow? In Korea, the impeller was not available. But so, how did you?
So we pre-treat with a lot of times with, ice intracoronary nitride and trying to at least improve the microcirculation. The right coronary, if you have a short, we don't use DEB in a clinical practice, we have it in research, hopefully get, but they're relatively long. So I think this one, I'm not sure how short a DEB, how short a DEB is available in Hong Kong.
Oh, we have the 1520s. Yeah.
15, 20?
Yeah.
Because this 20 may be even too difficult. So, but I think a DEB would be the right choice to, using a guideliner,
Yes.
Geisler to go down and just treat it. I don't think a stent would go down. The challenge on the left side is that how do you wire this darn thing with the rotablator wire? You're going to use a
think you need a
regular wire and then
microcatheter
microcatheter,
exchange.
but you may not even microcatheter may not go down.
Why not?
So you might have tried the rotor drive wire. I don't know what, do you have it in Korea as well, the rotor drive wire, which is a better wire for rotablator? Because this, you have to primarily wire this thing because, a microcatheter may not go down.
And looks like what they're doing, looks
Yeah.
like a microcatheter.
So we don't have the specific rotor drive, the wire, we just use different wire.
1.75 할까?
And microcatheter does not pass, and the proper scheme, you try to the small size balloon,
Yes.
okay?
Rotor wire does not advance because of huge frictional force between the wire and the calcified lesion. So I try to break a little calcium with a small balloon. The concern is blood pressure is not high enough to do procedure very aggressively because on the backup of dopamine 20, the blood pressure is not below 100.
So, Professor Park, in Korea you don't have impeller. So
Yeah, we
in
don't
patients
have
with now, for example, this patient's EF has improved a lot to 40, but if her EF has not been improved with the index RCA procedure, so if you have to deal with what the angiogram looked like today. So will you put in ECMO?
Yes, so ECMO, you know, there are several
Only-
type of
Stop.
the mechanical circulatory support devices, but the ECMO usually used for, final cities, shock and something like that. In the elective case, we don't do
가이딩 안 좋네.
IBP or impella.
So you seldom do preemptive ECMO, and then
We don't do preemptive ECMO.
Inflation, maximum.
Would you protect the ventricle? Would you protect?
Inflation,
This is IBP.
Yeah.
inflation, maximum. 겹친다 좀 해줘. Deflation,
The
maximum.
balloon size 1.0, 1.25,
1.75 deflation,
1.75. Okay.
maximum. Plus. Inflation. Deflation. With 1.5.
I think that the target region for rotor ablation of these cases will be mid-LAD, but I think that the ostial and the proximal LAD region is so ugly, and so during the rotor ablation, it's not that good condition.
I mean, we like to treat everything, but sometimes you can say
OMT.
surrender. Don't start.
We believe ischemia trial.
I think it's not depends on the patient, the LV ejection fraction is.
Good.
The 1.5 balloon cannot advance. I cannot advance the 1.5 balloon. The option is just introduce rotor wire and rotor ablation. It's impossible. Okay. Once again, 자, extension wire 장착해가지고.
And that's why a rotor-bladed-like system that can go over 14,000 wire. I think Medtronic has one coming out. Is really crucial, right? Because a lot of times these very difficult ones you cannot get a rotor-bladed wire down.
I think in this case, if the wire passed well and there is some room for passage of the shock wave, is the best candidate.
It still won't go down.
Shockwave's a little more difficult than an NC to deliver. It delivers okay, but it's a little tougher than even an NC. So it would, and it doesn't come this small.
That is not the holy grail. I mean,
You still have to atherectomize this. But then you might need still shock even after.
Even after, yeah.
Because it's the so-called rotoshock.
No benefit of balloon.
I mean, would you consider in the U.S. that this is use a laser to just basically trying to blast through some of the things, or
가이딩을.
blow up a balloon and blow it up?
그러면 위에를 먼저 트리트해.
I think that's a very interesting question, Alan. Because
0.9 millimeter laser catheter.
Yeah, we've done laser for no option calcified lesions.
That's it.
Yeah.
Now you're stuck, right?
Yeah.
You just blast it and see what
So I
happens.
don't know whether Antonio is in the auditorium,
Once
but
again,
he's
rotor wire.
increasingly using it in these tough lesions.
Laser?
Yeah.
Laser, wow.
Or granuloplasty, just blow up a 1.5 balloon there, just dial up to whatever pressure.
Yeah.
But obviously chances of perforation as well, being a 88-year-old woman, and you certainly cannot pass the cover stent in there. So I would say laser is probably the balance if you have a eczema laser.
I think they're going to
Yeah, balloon angioplasty was not helpful because I once again tried the rotor wire advancement. Okay.
So you have a microcatheter in there, just try the best you can to wire it. But
Okay.
That is the point that I reached before. Beyond this point, I cannot advance wire due to friction.
Oh, really? Oh, I forget about the rotor wire.
There's one option is to treat left main to proximal LAD.
Yeah.
전혀 안 움직이네.
I mean, there's a lot of proximal disease, so maybe just, leave the
Has to-
rotor-blade wire there and rotor-blade, the top part, and just,
이거 전혀 안 돼.
hopefully just open up some perfusion. It's not a whole lot of option.
I propose the LV ejection fraction of patient is so damaged, and so
Who's coming?
the left main LAD first should be treated, and then we will find a way to pass the wire in the mid LAD region.
오케이. 다시 갈까? 시온 와이어.
But the guide is pretty stable, actually,
Yes.
on the left, no?
Yeah, this is SB guide caster.
EBU?
EBU.
EBU? 3.5.
3.5. Okay.
A little bit weak. But after treatment to left main to LAD, we can change the guiding catheter to ambulance.
So I think this case is the typical example of the chip procedure. Yeah, absolutely. So complex.
환자 계속 움직이고 하니 어렵네.
From the reverse TAVR trial and the activation trial tell us
Is the flow disappear?
from the PCI before the TAVR procedure, we still know its benefits. So from current guideline always tell us maybe with patient
Okay.
have ACE and CAD, the guideline tells us maybe we only need to do the limit and the proximal region only. And even without aortic stenosis for this patient, this is still a cheap procedure for this patient. So we need more cardiac output. Maybe we need some MCS support. So for this patient, maybe we just finish the proximal region and try to put on the valve to get more cardiac output and plan for the stage procedure for the CAD. Maybe that would be better.
Okay, 자, shape. Test.
Antonio, the Pope, the Pope's coming. I mean, the Pope's here. So we have a very difficult case that, maybe you can enlighten us a little bit, enrich our knowledge. It's a very complex, probably one of the most complex that I've seen for a long time. Calcification, 88 years old. And, he has a very difficult time passing the wire in the LAD, very tortuous, right? And the question was, shockwave is out because not approved and shockwave wouldn't work here. So he's ballooning it, and the question was a laser. And I remember, we had some discussion about the laser. Would you use the microphone, maybe?
Okay, blood pressure is declining. This eye just try to treat.
Does he have balloon pump? Yes.
Here.
Yes.
Okay.
Maybe then go to balloon pump
balloon
1 to 1.
pump
Seems like going 1 to 2.
Which wire is he using?
Xi'an.
Xeon.
Xi'an, which kind of Xi'an?
Xeon blue.
Maybe so
Simple
calcific,
Xi'an.
maybe Xi'an black because it's very calcific, a lot of resistance. I will try Xi'an black. But
He was able to get down to the apex, but just the micro catheter would not go down to exchange for rotor-bladed wire. So
you can
now it's kind of
maybe you can go as distal as you can, or you can try to do some dilatation with a 1 millimeter, 1.5, 1 millimeter balloon to facilitate the microcatheter go down.
Yeah, they hit the mid-segment with a small balloon.
But if you can keep on inflating at high pressure, you can gain some lumen, and then you go down with the catheter. You take a 1 millimeter balloon, you go to 20 atmospheres, you break it. By the breaking, you
스탠트는 준비
make some
몰랐고.
room.
Sierra,
I will use the Sion black.
maximum inflation.
He tried to open the proximal part first.
Inflation.
Yeah. Open the proximal part is not bad. At least you get some flow. Blood pressure is okay.
자, stent.
What's the ejection fraction again?
2.5이었어, 금방.
36.
3
Worse
after.
before, but now improved a little bit.
Yeah, just
Left main 잘 볼 수 있는
microcatheter was
위치가.
obstructive. I think it was causing ischemia.
Just do something proximally first, at least get the.
Yeah, I think you should focus on the proximal.
So many lesions, get rid of some resistance as best you can. Is there a reason that you go 1 to 2 in a balloon pump and not give them even more support and go 1 to 1? Seems like you're just on 1 to 2.
1 to 1. 뭐하노? 김동현. 아, 영어를 못 알아들었은가? 아무것도 안 들려?
Okay, I think this is a tough case, and that the most panel and the moderator is anxious. I think we cannot imagine is it operator much anxious. Yeah, absolutely. This is a live case. Yeah.
I think during our sort of lifetime of doing cases, there are always cases like this. You feel like you're stuck in somewhere, and then you know that you have to get out of there. So you're scratching for, like, you're falling down a cliff. You have to grab to whatever you can grab to.
어디갖고 또.
So there are two people that never surrender, Professor Kim and Dr. Colombo.
A little bit there.
Yes. The what size stand?
3-0 maybe.
3-0.
3-0.
쓰네.
Why don't you come to the mic up there and then you don't have to.
조금 더
Just take this back, yeah.
깊어.
Yeah.
아래 크라니아.
Absolutely, I'm sure this is
피하고.
most difficult case in TCTAP.
피해야지. 앵글. 그 말고. 오케이. 자, 갑니다. 쓰네. 별로 더 안 되나?
Not bad. You see the distal vessel, it's okay. Blood pressure
자,
is stable.
테스트 준비.
Gonna be all right.
Are you still using balloon pumps?
Not much.
가이드 안 했던 거
Occasionally.
있지?
You know,
지금 뺐지. 다시 쓰네.
Impel is very expensive in the United
Okay.
States. Even though it reimburses, it's still.
인플레이션. 테스트.
Balloon pump is practically free.
카우달 디플레이션.
Is the right coronary artery open?
Yes.
야.
Okay, so
맥시멈.
Not perfect, but the middle part of the right corner is also has a lesion. That cannot be stented because it's corkscrew calcification.
It's kind of open.
Yeah, it's better than it was last week.
Yeah.
쓰네.
But it's very tortuous too.
Yeah, it's not stentable.
Okay, flow much
자,
better.
크라니알.
And much better. Yeah. And AP cranial, take a look at that.
네.
Good, much better.
Well, that's
That's
much
better.
better.
Yes.
I think it may be time to declare victory.
It's one lesson for young intervention is that don't lose your mind at any time. Yeah, that is so important. This is like some complex case. Yeah, is that young intervention is the very anxious and you know.
You could accept this result.
What about the change of strategy from LAD to big diagonal? As you can see, diagonal ostium is tightly stenosed. And a little bit.
Yeah,
Not a very big vessel. How big is your guide catheter?
Yeah, diagonally is big enough, but I think that middle the concentration is much more important.
Yeah, I think mid-LED is more important. There's a lot of septals coming out.
But actually, the balloon is not passed.
But if he's, is he taking catecholamines or only balloon pump?
Any vasoactive drugs going on?
Only balloon pump.
So try to switch off balloon pump and see what is blood pressure. Yeah, just a minute and nothing happened.
Okay.
Dr. Gibbs, the proximal LED region was so dirty and stenotic, but you
Yeah.
dilated it, and so it is deserved to try again the middle LED rota
Yeah,
wire.
but a mid-LED, if you don't have good runoff, I will not touch mid-LED. You need better to leave it like this than.
Antonio, do you have the rotor drive wire in Milan? Like, the new rotor wire. Rotor is much better in terms of
No,
primary
we don't
wire.
have it.
Yeah.
But if this wire doesn't go down,
Yeah.
it's
It used
no
to go
good,
down.
You see on black?
Antonio, and at this moment, sometimes we try to pass the rota wire, it does not pass. How can you do at that moment?
But I, as I said, I advance a micro balloon as much as I can and keep on advancing and dilating, and then I try with the micro catheter. And I go as distal as I can with the, but you have to overcome that stenosis because the rota, if this wire doesn't go, the other will not gonna go.
Terrible.
But I will change the wire. I don't know if I do the diagonal.
Is he trying the diagonal? Is he trying?
I
So
think
we have
diagonals are never so.
이게 더 뭔가 타이트 리전이네. 테스트 해볼까?
I think laser and the LED would be the when
Antonio,
you're able to
I will
go
take a micro catheter and change the wire. Take a fresh wire, like a Fielder XTA or Fielder XTR, very small. You may be able to cross.
To cross what, the LED?
Yeah, they cross the LED and then use a 1 millimeter balloon.
1 millimeter balloon.
Would you also do the diagonal?
I will wait. I will concentrate on the LED.
Dr. Kim, what is the name of the microcatheter using now?
Corsair.
Corsair.
XS.
Access, okay.
Corsair is okay.
AP.
But it's very easy to be on this side than on the other side.
Dr. Hwang, Doyeon, save the contrast volume.
Okay, thank you.
The wire is kind of used up a little bit.
Did you get a fresh one? Yeah, the tip is beat up.
Yeah.
It wouldn't even go through the die, so it must be beat up.
a new wire.
자,
Almost there.
1-0 balloon.
Okay, much better.
Yeah, you see. Which wire? Is the same wire?
This is which wire?
No.
Sion black. Okay,
Yeah.
good.
When
comment
you
the
have
work.
this calcific lesion, Sion black is the way to go because it goes distant.
Antonio, comment work.
Yeah.
I think if you, in the States, at this point, you put a laser out. Because the balloon is not going to use a 0.9 millimeter just
What do you
blast through.
think?
Huh?
What do you think about the laser?
The laser, if you have a laser, I do laser with contrast.
Yeah.
But
Blow it up, yeah.
we don't have laser anymore. It's okay. But you can do with, I will take one, inflate the balloon there, keep on inflating it, do some granuloplasty.
So, and this is
Yeah,
last.
previously,
yeah,
the balloon reached at this
inflate.
moment, at this
Yeah.
point,
I
but
think you
it
should
is impossible
blow up the
to
balloon
advance
now.
Blow up the
more.
Yeah,
balloon
just have
there,
to
blow up the balloon.
rupture the balloon. There's no other
Rupture the
choice.
balloon, take various balloons.
But very
I
nice.
already ballooned this part.
But rupture the balloon. Go to
Rupture?
whatever. Rupture.
Yeah, you, Antonio, you
When
recommend
you
the
do plastic.
1.0 or
Dr.
the
Kim.
much small balloon, small size
Okay.
balloon?
As you advance your
1
balloon,
millimeter,
the
0.9.
the
is
guiding
small.
catheter was
Watch out the guide, watch out the wire, don't lose the wire.
가이딩
And make
카테터를
sure that the
바꿀까?
wire is hydrophilic,
Guidezilla.
doesn't perforate.
가이드질라, 오케이, 가이드질라 좀.
So Antonio recommended the small size balloon. Yes, you know this time is limited 30, but this last case, many people crowded this room and wanna watch it more.
Yeah, we keep going.
그래요.
They cannot rotablade because they cannot go with the wire.
So-
This is a regular wire.
The microcatheter won't go down.
So
That doesn't cross the corsair.
They don't have a rotor drive wire. So
another live valve mitral clip case was a standby.
Really? Yeah.
So
How many times can I use? How many minutes?
it's a,
oh yeah, they can
okay.
What are you taking
minutes.
now?
Okay, we can see more 5 minutes.
5 minutes
Okay,
Just the
thank
5
you very
minutes.
much for your.
with the guidezilla and then
Prof, the boss said 5 minutes.
Okay.
blow up the balloon. In a way, that's what we want to do. We want to have granuloplasty.
Many audience watch for this case.
자, balloon.
Now you have a relatively fresh stent there, so be careful not.
But the black
Yeah.
really, the black really made a difference. You know, it went down.
Let's put the Xion black and then.
But take a new balloon, not this.
Yeah, new balloon.
Yeah.
What
1.5.
size balloon? What size balloon?
1.0.
Okay.
1.0.
Guidezilla. Okay.
Blow it up.
No.
Usually at the proximal,
Get power with the guiding catheter first. Engage well the guiding catheter.
There's
Keep
a-
it in.
There's a guideline.
Watch
There's a
out,
guidezilla there.
and then go with the Godzilla. Take your time. You have time. It's okay. You have to dilate more the stent. Dilate more the stent. Take a trio balloon, 20 atmosphere approximately. Dilate the stent, and you can
Okay.
make room for the Godzilla.
아까
You have time.
3.0.
He has
3.0.
never-
30,
never
20
been so patient
atmosphere.
with me, you
Dilate
know.
the stent very well.
어? 세열이.
Dilate the stent, and then the Godzilla will go down. Yeah, 3.5. 3.5.
After coming Colombo atmosphere this room to America.
But I think these are important problems to solve.
know.
It's good.
I mean, I think you have to always think about in your lab, in your country, if you cannot get a microcatheter across,
Oh,
what is the choice?
this is a common problem.
Yeah, you have to
Common.
figure
I
out what
get
to
it these every 2 or 3 months. But it's. But I think you have to. Blood pressure, as long as you don't have CPR, is fine. If blood pressure is stable, take your time, relax. It's going to be all right. The wire is distally. Don't lose the wire.
어디 있나? 또 이거는 또 작은 거 좋네. 아, 참. inflation. 6?
This is
Okay,
a
yeah.
different balloon.
And the other.
3.0 here?
Yeah,
that's one.
with the balloon
Small.
inflated, get the guide liner in. Get the guide liner in with the balloon inflated. Keep the balloon inflated and go down with the guide liner. Go down.
Good.
Go down more.
Excellent,
Beautiful,
excellent.
beautiful.
There you go.
Beautiful. Deflate the balloon. Advance the balloon more. Advance the balloon more and inflate it again. Okay, get the guide liner down.
But the problem is the
It's
pressure.
okay,
density.
don't look at the pressure, just look at the wire.
Plus
When,
deflection.
if the wire moves, it's okay. As long as the wire moves, is good. Go down with the balloon.
Inflation.
Okay, get the guiding catheter better. Get the guiding catheter. Okay.
Deflation.
Okay, go down with the balloon a little bit more. Go down.
It is
go
impossible.
down. Don't look at the blood
Inflation.
pressure.
Inflation.
Get the wire more distal. Okay, inflate. Go down with the guideliner. Get the guiding catheter better in position. Keep the, no, guiding catheter is no good. Get the guiding catheter better. Okay, that's fine.
That's maximum.
Okay. Keep the guideliner, the Godzilla there,
10.
and take a 1 millimeter balloon. Don't look at the blood pressure.
Yes, and then try to the 1.0.
Yeah, with the Godzilla like that.
So we have remained
Yeah.
3 minutes.
Yeah. This is a ventricular blood pressure. Very good. Good ventricle.
It's the guide.
It's the guideline. Yeah. Oh, guideline.
This is the pressure from the Godzilla. Don't worry. Means that there is a good flow. Distal. Yeah.
Where is it now?
Okay, this is 1.0.
Still not good.
Doesn't go anymore.
Inflation.
Okay.
This is a 1 millimeter.
Yeah.
1 millimeter. 1.0.
Yeah, 1 millimeter.
Whatever average scale.
You know, as the last resort, if you can try, do like this. Go with the microcatheter as distal as you can.
Inflation.
As distal as you can. And then take the rotablator wire.
They tried already.
Yeah,
They
it's
work.
okay. As distal as you can. Take the rotablator wire and wipe the rotablator wire with the white stuff, the one that gives the anesthetist. What's the name? Propofol.
Propofol.
Wipe the rotablator wire with propofol. Becomes hydrophilic and will go down. They don't have it.
Okay.
No. Okay.
Blood pressure is
Blood
low.
pressure is okay. Blood pressure is a ventricular blood pressure.
Okay.
As long as the wire moves, it's
Microcatheter.
okay. And sometimes talk to the patient
Excess,
and
yeah.
make sure that he talks. You see, the wire is moving well. Keep on advance. Don't lose the wire.
잡았어요.
Which size balloon is this? Or that's a
Yeah,
microcatheter?
and now and then
Okay,
we
go
try
with
to-
the
Microcatheter
microcatheter.
advance.
Okay,
Go to
good.
the microcatheter, distal as you can.
와이 잡아야지.
Okay.
Where is the microcatheter?
Yes, it's, they are going up. It's coming. Okay.
No,
What's the wire? What's the wire?
Is that the same spot?
it cannot advance anymore.
Okay, go as much as you can. Okay.
Rotation.
Yeah.
Are you ro-
Now try with the rota wire.
are you rotating the course axis?
Okay.
Yeah.
Rotate it counterclockwise.
Yes, and Antonio, you recommend at this moment as much as push
Yeah.
and then change the rotor wire.
Yeah, try and change with rota wire.
It doesn't advance. You need to check the tip of the microcatheter.
Okay.
Yeah.
Rotor wire once again.
Yes.
Put some hydrophilic stuff on the rota wire.
After singing the past rotor wire, we're gonna finish this live. Yes, we move to another.
Has to be a new rota wire. Well wet. And you have to pray a little bit also. Easy. Did you make a small curve on the rota wire? A small bend on the tip? Minimal? Make a minimal bend.
He's coated with propofol, right?
No. Slowly.
안 되네.
You see the difference between polymer coated and non-polymer coated.
자, 테스트 해볼까?
Okay, and absolutely, frankly speaking, I want to see more, but we have a very tight schedule, and we're going to finish this session. And Professor Kim, thank you very much. This wonderful,
Fantastic.
case, and we're going to move to the next session. Thank you.